Hi, good morning, everybody. Is everyone able to hear me?
Yes, a little more louder would be good.
Yes,
Okay,
madam.
okay, great. I think we had the same problem last year where there was some problem with uh,
I
the
think it's perfect,
microphone,
ma'am.
and
I think it's
it's
perfect.
okay right now?
It's okay.
Wonderful. All right, so I'm going to share my screen and let's see. Okay, I'm hoping everybody can see my screen now.
Yes, ma'am. Good to go.
Yes, we can.
Excellent. So thank you, everyone, for coming for today's session. And I'm very happy to be presenting our perspective, our center's perspective on managing a very important and very common symptom in patients with advanced diseases and very commonly seen in patients with advanced malignancies. And that's where most of our research and experience comes from. So this is usually the slide that I begin with, which is this schematic diagram which shows the pathophysiology of nausea and vomiting and the various receptors which are involved in mediation of these symptoms, namely nausea and vomiting. And if you can see at the center of it is the vomiting center and the chemoreceptor trigger zone. And then the central nervous system, the gastrointestinal tract, and the vestibular apparatus are very important as well in mediating nausea as well as vomiting. And the receptors, which are very commonly involved in these mechanisms, are the 5-HT3, D2, acetylcholine, NK1, and the histamine receptors. So really the assessment of nausea and vomiting and even the refractory nausea and vomiting is a thorough history, physical examination, review of medications, review of bowel movements, frequency, any other medications, concurrent medical conditions, infections, and then laboratory investigations and imaging as indicated. So, choosing the treatment for nausea and vomiting, there are generally two approaches. One is the mechanistic approach, in which you try to understand the pathophysiology and the receptors which are involved, and then choose your medication. The other is you know the patient's history and you choose sort of a broad-based antiemetic, which will involve multiple pathways and lead to symptom relief, and then based on that, you modify your treatment. So this is a table which is very useful because it has the commonly used antiemetics and their receptor profile. So if you can see right at the top is olanzapine, which is a really broad spectrum antiemetic, and it targets multiple receptors and has good affinity to most of them. Also well tolerated by patients, at least the ones that we see. And if you see metoclopramide is another one which acts on multiple receptors and is also very commonly used in our patient population. And then if you contrast it with drugs like ondansetron or the aprepitant family, they're usually narrow spectrum ones and they only target one or two receptors. So let's jump into a case, and we have a 60-year-old with stage 4 colon cancer with mets to the liver, and he's currently receiving chemotherapy. He has cancer-related pain for which he takes morphine, short and long acting. And his pain is well controlled, but he comes to you with nausea, early satiety, postprandial fullness, and feeling bloated for about 2 weeks. He has vomiting along with nausea, and it occasionally contains food, and he has some relief after uh, the episode of vomiting. He's been trying Zofran as well as prochlorperazine, uh, and that's not giving him much relief. So, what additional information would you like for this patient? And maybe you can just put it in the chat box. And I'm just going to take a couple of seconds here to see if we have any responses. Maybe someone can let me know if there are any responses that I'm missing or I'm not. Okay. So moving on, one of the important things that you always need to evaluate when you're getting symptoms which are mostly GI based are bowel movements, and especially when somebody is on opioids to see if our patient has opioid-induced bowel disease, because that is one of the most common causes of nausea um, in a lot of our patients. And just treating the opioid-induced bowel disease sometimes can help with alleviating of symptoms. And if you look at the etiology of nausea in this case, it is most likely because of opioid-induced bowel disease. And the receptors which are most likely to be involved are dopaminergic and muscarinic receptors. So, how do we treat this case of nausea? So, for impaired gastric emptying and opioid-induced bowel disease, which is almost 35-40% cases of nausea and vomiting that we see, um, it can also be included with other symptoms like nausea, postprandial fullness, dyspepsia, usually caused by opioids, which have a direct effect on chemoreceptor trigger zone, on the gastric antrum, and also the vestibular apparatus. So the drug of choice is metoclopramide. And there are many benefits of using metoclopramide. It is cheap, it is effective, it is a prokinetic agent. It is available in multiple formulations. It can be taken orally, IV, sub-Q, and in the United States is also available as a nasal spray. So we use that in 15 milligram, one nostril, 4 times a day. The limiting factors are sometimes extrapyramidal side effects, although in our patient population, we rarely see this. So this is frequently our first line therapy drug of choice for most patients that are on opioids or have advanced cancer and come with nausea and vomiting. So you start your patient on metoclopramide, and then he's also taking ondansetron concurrently with this. You start him on a good bowel regimen for constipation, but he comes back to your clinic 3 days later still complaining of nausea. So what do you do now? Um, so for second line agent, or if somebody has persistent nausea despite initiating Reglan, it's important to remember that nausea is a common side effect of most opioids, and patients do develop tolerance to it, but sometimes they don't. And at that time, if you can associate the symptom of nausea with the opioids and the time at which the patient is taking the opioid, a strategy to consider is opioid rotation. And switching to another opioid at equianalgesic doses can reduce the symptoms of nausea for some patients. Treatment of constipation and assessment of bowel movements at every visit is extremely crucial, and a lot of times just treating the constipation improves the symptoms of nausea and vomiting. And then, of course, you can try second line agents like olanzapine, which are also very beneficial in treating nausea. So this is what you end up doing. You increase his Senna to 4 tablets twice a day. You discontinue the Zofran, and then you substitute that with olanzapine as the second line medication, and ask him to take it 5 milligram twice a day as needed. And you check up on him in 2 days, and now he's having improvement in symptoms. So remember, opioid-induced bowel disease, you can try opioid rotation, treatment of constipation, but metoclopramide is usually the drug of choice. Um, so coming back to this case again, now you are doing your inpatient rotation and you are in the acute palliative care unit, and your patient is now admitted. He was admitted initially to the main hospital in the ICU for septic shock and now has been transitioned to full comfort measures in the acute palliative care unit. But now he's terminally ill at the end of life, unable to swallow. He has episodes of agitated delirium and ongoing nausea with intermittent emesis. So, how would you manage his nausea and emesis now? Metoclopramide again can be used as long as there is no evidence of complete bowel obstruction, and we use it IV, sub-Q. We use it in divided doses, or we can use a parenteral drip, and that is also effective. The other choice, which we use very commonly in the acute palliative care setting at the end of life for refractory nausea, is IV haloperidol. And haloperidol is a dopamine antagonist. It's a centrally acting agent. Again, it can be given orally, IV, and sub-Q. It causes less sedation than other antipsychotics like chlorpromazine, but it does have more extrapyramidal side effects and does prolong QTC. So these are the two things to be, cautious about. And you can use it in cases of gastrointestinal obstruction. So this is again one of the drugs that we highly use in our patient population and with good efficacy. The other advantage of haloperidol used in setting of terminal delirium and agitated delirium is control of the restlessness and agitation symptoms. So you start your patient on haloperidol and he has relief with his symptoms and then passes in the palliative care unit comfortably. Going on to this next case, you see a 48-year-old lady. She has stage 4 metastatic breast cancer and she's currently on chemotherapy that has cisplatin in it. And again, she's taking ondansetron at home and has intractable nausea, vomiting, anorexia. She has weight loss and severe nausea, which is currently not being controlled with her regimen. So, what is the etiology and how do you treat this patient? So, this patient has chemotherapy induced nausea and vomiting, and usually chemotherapeutic agents can be classified according to their emetogenic potential. So, as you can see, this patient is on cisplatin, which is in the high emetic category. And so, upfront, this is somebody that we would put on a anti-nausea regimen or one of those regimens with 3 or 4 medications with her infusions to prevent chemotherapy-induced nausea and vomiting. So prevention is possible by choosing the right set of medications. This is the table and the guidance from the MASC Society. And as you can see, for highly emetogenic chemotherapy agents, we use either a 3-drug regimen or a 4-drug regimen, and these include the NK1 receptor antagonists, 5-HT3 antagonists, dexamethasone, metoclopramide, and nowadays olanzapine is added to most regimens and has shown statistically significant reductions in nausea and vomiting. For minimal symptoms, again, metoclopramide is the drug of choice, and we recommend really going with this before using any other agents. Serotonin antagonists are also widely used. These act on the serotonin receptors. They are not as broad spectrum as metoclopramide or olanzapine, but some of the advantages are that you can dose them Q8 or Q12 hours. They are available in orally dissolving forms. Things to worry about are prolonging QT intervals and also cost. Headache and constipation are the most common side effects that we see in our patient population. NK1 receptor antagonists, we mainly reserve these medications due to their cost and again their spectrum of activity in patients receiving highly emetogenic chemotherapy protocols, and they're usually given during their infusion. We do not use it on a regular basis. And again, we recommend using either metoclopramide or olanzapine as the first and second line agents for most patients. So you see your patient, and then because her symptoms are not controlled on the first line regimen, you add olanzapine twice a day. And then you see her again at 1 month follow up and 3 months follow up, and then you see that her symptoms are actually better. She has even improved appetite, is gaining weight, and overall feels better. So olanzapine is really a drug that has emerged very successfully in the last 5 years and has been increasingly used. And we have seen good results and good efficacy in most of our patients. So it's an atypical antipsychotic. We discussed the receptor profile previously, but this is again a revision. And it's interesting to note that it has other effects which are beneficial for patients with advanced cancer, like anti-anxiety effect, and it helps with anorexia and also sleep. So we find actually multiple benefits from one drug, and that is why we like it. Most of the studies that have been done on olanzapine have used the 10 milligram dose. We find that dose sometimes sedating in young patients or very old patients. So our process is generally to start with a 5 milligram dose, dosed every 8 hours, or for some patients, even a 2.5 milligram dose helps. Um, Other benefits of olanzapine compared to other antipsychotics are that it is less QT prolonging, especially if you compare it to haloperidol. So these are some of the studies, and as you can see, there's plenty of data available from really high quality randomized control trials and systematic reviews of RCTs, which has shown a benefit of olanzapine both as a first line drug and also for breakthrough nausea. And even in the absence of chemotherapy induced nausea and vomiting, there is benefit of using olanzapine. Some of the side effects that we need to keep in mind are extrapyramidal symptoms, and the most common one we see is akathisia. So we give patients a warning before that they could experience restlessness or agitation, and if they do experience these symptoms, we just discontinue and then substitute it with another antiemetic agent. So akathisia, extrapyramidal symptoms, sometimes restless leg are the symptoms that we see. It does cause QT prolongation, and you have to be considerate, especially if you are using it in patients with underlying heart disease or prolonged QT interval at baseline. You need a lot of monitoring, but it is definitely less risky than, say, using haloperidol or chlorpromazine. So moving on to another case, you see a 48-year-old lady with stage 4 non-small cell lung cancer. She has brain mets, and she comes with intractable nausea, and she has headache as well as vomiting with it. Additionally, she is complaining of new right arm numbness and weakness, and she also has ongoing headache, and the vomiting is usually early in the morning. So again, it comes back to the same question, what is the etiology of her nausea? So the answer to this is raised intracranial pressure. And for patients who have intracranial metastatic disease, either primary or secondary, this is one of the sometimes initially presenting symptoms and sometimes a very debilitating symptom. So the drug of choice is dexamethasone, and I say dexamethasone because that is what we generally use. It has less mineralocorticoid activity, and that is why we prefer it to other steroids. Methylprednisolone or prednisone can also be used. Um, it has some benefits also in reducing the overall intracranial pressure, help with pain, and improving appetite. And so it's also beneficial to our patient population. But if dexamethasone generally doesn't work, then either surgical management or sometimes adding diuretics or acetazolamide can also be tried, although the evidence is just purely anecdotal and limited. So you start Mrs. G on dexamethasone 4 milligram twice a day, but she still continues to complain of headache and nausea despite 2 days of treatment. So what is going on here and what can you do? So remember, it usually takes 72 hours or sometimes 48 hours or more for dexamethasone to exert its action. And you can increase the dose because it has a dose-dependent activity on the intracranial pressure. So if you increase the dose, sometimes patients derive more benefit. So that's what you do. You increase her dose to 4 milligrams every 4 hours, and she has relief of symptoms. And then the dexamethasone is slowly weaned off over a period of 2 weeks. Moving on to a new case. You see your patient, the one you saw a few months ago, who was on chemotherapy with cisplatin, now is on a chemoimmunotherapy regimen, a new regimen that she has recently started. And she complains that she has ongoing nausea, and it starts as soon as she pulls into the parking lot of the hospital, and she knows that she's going to get her chemotherapy infusions. And additionally, she feels anxious, she begins to tremble, and has the sensation of emesis. So, what is your diagnosis and how will you treat this? So, this is anxiety associated nausea, vomiting, also called anticipatory anxiety, which leads to the symptom of nausea and usually has a cortical component. The first line treatment is behavioral treatment or CBT. So this should be tried first rather than going directly to antiemetic agents. If behavioral therapies or CBT doesn't ameliorate the symptoms, then in severe cases, trial of benzodiazepines is reasonable. But just remember that benzodiazepines, along with opioids, can cause respiratory depression. They can cause sedation just by themselves and should be avoided in elderly patients and especially those who are on high dose of opioids. So, putting it all together, according to the recent guidelines from 2021 from the MASC Society, which is the Multinational Association of Supportive Care in Cancer, the first line treatment is usually metoclopramide and haloperidol based on level 1 and level 2 evidence. And then olanzapine and methotriptamine, which is not available in the US, are usually second line. And then tropisetron and levosulpiride are third line according to their guidelines. And again, these two are medications that we do not use at our center. Levosulpiride is not used. Again, caution with levosulpiride in patients who have extrapyramidal symptoms. So moving on to case number 5, we have a 50-year-old lady who has stage 4 ovarian cancer. She has peritoneal metastatic disease, and she comes to the emergency room with nausea and emesis. And additionally, she's having abdominal pain. She's having large volume emesis every time, which is brown in color. It smells of stool. She's been taking her opioids around the clock without any relief. And I see somebody wrote in the chat box obstruction, and that's absolutely right. And I know you're going to discuss a case later on for malignant bowel obstruction, so I won't go into much details. But this is like one of the causes of refractory nausea, vomiting, persistent symptoms of nausea, vomiting. So really, what is the etiology? What additional investigations would you need, and what receptors are involved? So these are the questions that you have to go through every time you're treating nausea and vomiting. And so it's important to remember that you start with plain abdominal films, you start with laboratory investigations, dehydration, and then also consider, do you need a surgical consultation? So not every patient will qualify for that, but for those who do, and this is something that you need to, consider upfront. i- If this is a patient who has a greater life expectancy. There's only one site of obstruction. There's a clear mechanical obstruction that can be reversed. The patient has good performance status, doesn't have any concurrent comorbidities, is younger in age, and will survive a surgery. We recommend that you get surgical consultation first to see if there is surgical correction possible. Also, this is a good opportunity to discuss goals of care with the patient and the family if hasn't been done before, because this usually, affects the prognosis of the patient, will affect oral intake, and so these conversations should generally start. If you have a patient who has a poor performance status, has multiple medical comorbidities, multiple sites of obstruction, and prognosis is generally less than 2 months, then these patients usually are managed conservatively. And the conservative management usually involves, first and foremost, bowel rest. So, nil per oral, and usually will require IV fluids, NG tube decompression, and then really management of symptoms like nausea uh, and pain. So this is what you end up doing. You start her on a hydromorphone, patient-controlled analgesia. You write orders for bowel rest, normal saline, and then you start haloperidol for nausea. But she still continues to have severe nausea and vomiting. And so what do you do next? So somebody wrote steroids, and that's right. So next line of treatment can involve antimuscarinics and corticosteroids. So corticosteroids reduce gut wall edema and also have a central antiemetic effect. And anticholinergics are also useful in decreasing the symptoms of nausea and abdominal colic when there is mechanical bowel obstruction. So agents like hyoscine, scopolamine can be used. They do cross the blood-brain barrier and have central nervous system side effects like sedation. Alternatively, where available, glycopyrrolate can be used because it doesn't have CNS side effects. Let's see. So you try treatment with steroids and glycopyrrolate, but she still continues to have really high volume emesis, and her NG tube continues to put out a lot of fluid. So what do you do in this case? What is the next line of treatment? So the next line of treatment, which is actually very evidence-based, is octreotide. And octreotide has been recommended as the first line treatment for high volume malignant bowel obstructions and reduces the intra-abdominal pressures as well as the volume of emesis. The limitation of octreotide is usually cost, and in our centers across the US, that is one of the reasons the use is limited to cases of high volume malignant bowel obstructions. So some more facts about octreotide. It can be given subcutaneously. Usually we use it in the doses of 50 to 200 micrograms 3 times per day, and um, usually has significant improvement in symptoms within 24 to 48 hours. Surgical approaches, like we discussed, are favorable in patients with good performance status, single site of obstruction, and when the prognosis is greater than 2 to 3 months. However, if your patient is a poor candidate for anesthesia or has recurrent disease, then it is the time to have goals of care discussion and go for conservative management. Some endoscopic procedures which can be tried in patients include gastrostomy or the PEG tubes, which are for venting, and this is for relief of symptoms. Palliative stents, again, for patients with good performance status and longer prognosis, can be done at centers where such facilities are available. So if we look at the mask guidelines, octreotide is the frontline therapy for malignant bowel obstruction, and there is good evidence level 1 to 2 for the use of octreotide. Second-line therapies can include haloperidol and olanzapine, and olanzapine is also available in an orally dissolving form, which can be used in patients with malignant bowel obstructions. Other agents that can be tried are 5-HT3 antagonist, anticholinergic, corticosteroids. Metoclopramide can be tried, but only in partial bowel obstruction. We do not recommend the use of metoclopramide in complete bowel obstruction. Other medications that can be used for refractory nausea and vomiting, where the evidence is limited, but there are some case reports and case series, are cannabinoids. Um, because of regulatory and legal issues, we do not use cannabinoids for nausea and vomiting. So it is not our practice to prescribe this, but there has been some benefit in chemotherapy-induced nausea and vomiting. It is to be remembered that cannabinoids can cause sedation along with respiratory depression in patients who are taking opioids, especially methadone. So you have to caution patients when they are concurrently on cannabinoids and opioids. Non-pharmacologic measures which can be used along with pharmacologic measures include relaxation techniques, oncologic massage, acupuncture, and there is some evidence for using ginger and chemotherapy-induced nausea vomiting. And that brings us to the end. And I'll pause here and see if I can take any questions.
I can't see any questions.
Mhm.
I was just wondering, can we go ahead with Dr. Amelia's presentation and then we take up questions together?
Absolutely. I will try to stay, but I am on service today. So if I have to leave, if you can email me the questions, and I'll be happy to respond to them later on. But I will stay for Dr. Amelia's presentation.
Sure. Thank you so much. Thank you so much. And thank you so much, Amelia, for doing the session. So I know that it is not much different most often from the global scenario and when we compare the practice in India, but I'm sure there are certain things which uh, might be different from what we are doing here. Over to you, Amelia.
Okay, good evening. Thank you. Thank you for the opportunity, Sri, to talk. And Dr. Sonal, thank you so much for your talk. I think you've covered most of it. I'll try and see if I can give a different perspective, as Sri said. So the topic that I also have is refractory nausea and vomiting. Can you see my screen, please?
Yes, we can.
Yeah, okay. So I'm going to try and do definition of the physiology, causes, their management, and palliation. Let me see if I can just start off with definitions. So most people, there are many reasons why somebody might bring food out through the mouth. So when you go to take a history with anybody and they say we vomited, many times it's important to understand what they actually mean by vomiting. Okay. And what is nausea. So we do have people who say I've vomited and vomited, but then when you actually, and they come to you with these spittoons and you look inside and it is just froth or it's just some water. It's not actually vomit. So it becomes very important for us to differentiate these so that we can actually give the appropriate treatment. So it's an unpleasant, painless, subjective feeling. So what nauseates me doesn't have to nauseate you. What could trigger vomiting in me doesn't have to trigger a vomit in you. So just as pain is very subjective and has to be individually managed, so does nausea have to be. So it's more than vomiting, it is the nausea, and it is nausea that is more disabling, feels worse, and lasts longer. And people who are nauseated actually complain and say that their quality of life is actually affected a lot because of the nausea. Vomiting, they feel, oh, if I've vomited, for whatever the cause may be, if I have vomited, then I actually feel better. With nausea, the reason it is more disabling is because it's associated with all these autonomic feelings of sweating and feeling pale, salivation, sometimes blood pressure goes up, your heart rate goes up, there is vasoconstriction, you feel cold in your hands, and all of that is actually attributed to the autonomic nervous system. So you have all these other paraphernalia of symptoms that worsen this nausea, and there is no relief from it. So it is more disturbing. You also have any of these things that are there. There is retching, which is basically dry heaving. It is reverse peristalsis, but there is no expulsion of your stomach symptoms. So that's just retching. Next is regurgitation, where you have a passive flow of contents from the esophagus into your mouth. Then you have dyspepsia, which is chronic or recurrent pain right in the epigastric region. And then you just feel this water brash, you feel nauseated, you feel like you want to puke, you feel like the upper abdomen is actually uncomfortable. So any of these things is possible, and hence it becomes very important to differentiate that from vomiting, which is actually the rapid, forceful evacuation. So you're forcing yourself in a retrograde manner. Everything that's most of it's in your stomach is actually going to come out to the area of least resistance, which is your mouth. That is actually vomiting. None of the others can be defined as vomiting. Ma'am has actually gone through the chemoreceptor trigger zone, the vomiting centers, the reason why the chemoreceptor trigger zone is the most sensitive area, because there is no blood-brain barrier there. So it's important for us to understand that, okay? Next comes the fact that you have to take a good history. As with any symptom in medicine, if we don't take a good history and if we don't perform a good examination, coming to a conclusion or a differential diagnosis becomes very difficult. Now, Dr. Sonal very nicely went through many case histories where one leads into another and the causes are different in each. So if we haven't taken a proper history, then that is not going to make much clarity for us. So whatever the options of management may be, if we don't actually take a proper history, it does not guide us. Always remember, your general examination can give you loads of information about a patient. The vital signs can give you a load of information. Are they dehydrated? Is there pain? Is there any edema in the legs? Is there pallor? Are they bleeding inside? Have they had lymph nodes? Are there any lymph nodes up? If the lymph nodes are up, especially supraclavicular, in abdominal issues, you know that there are other issues going on in the tummy. Please look at them. Are they jaundiced? Do they have spider nevi? How are they breathing? Is there ascites? How is their chest movement? Is it abdominothoracic, or how is it? Are they using accessory muscles of respiration? Any of these things are going to guide you in your management. The mouth is a wonderful window to the entire GI system. So if you're going to think of the possibilities, it starts from pallor, starts from dehydration. Is there coating on the tongue? Are they feeling nauseated because the taste is gone, because the tongue is coated? Is there oral candidiasis? If they're on chemotherapy, is there mucositis? Is there ulcers in the mouth? Are those ulcers having bleeding points? Is there halitosis, bad breath? What is it? What is going on in their mouth? Do they have any pus in their mouth? All of these things are going to make them nauseated and vomiting. Remember that when we examine somebody, we can actually look at them, we think, oh gosh, it's really smelly, and we walk away. The smell's gone, but these patients have to live with it. There is a patient I've had who's had a very bad malignant breast ulcer. It was smelling so badly. Her nausea was something that troubled her immensely. But the minute the infection was controlled, the minute we were able to handle the breast wound, her nausea just disappeared. So please remember that though we give you an algorithm that these are all the possible causes of nausea, vomiting, you will have to put a clinical picture together if we have to have a good symptom management. Neurological signs, kindly look through all the bloods, especially electrolytes, high calcium, hypercalcemia. One of the most common symptoms of hypercalcemia along with constipation is nausea, vomiting, and they're extremely dehydrated. Sodium is a very important electrolyte in nausea, vomiting, as is magnesium. Kindly look at this. And if they have been truly vomiting, then potassium would have fallen. Chloride issues will be there, which means ileus, abdominal distension, all of these are secondary to that. So please put in all your investigations, your history, your examination together to come up with a differential diagnosis. So I won't go into details of this. It's just a simple way of helping you remember the causes of nausea, vomiting. Ma'am has gone through it in a case form. I'll put it into a nutshell into this. So I'm going to go through it as 10 M's of nausea, vomiting. The first one is metastasis, as ma'am had discussed. It could be cerebral or liver. Causes are the raised ICP if it's brain, and if it is in the liver, it is because the toxins that are produced, the chemokines which are produced, the cytokines which are produced are going to trigger the chemoreceptor trigger zone where the blood-brain barrier is not there. And hence you're going to have nausea, vomiting because the chemoreceptor trigger zone stimulates the vomiting center. So your medications would be mannitol, Dexa, or dopamine, which is haloperidol. Okay, so you could have meningeal irritation because of leptomeningeal disease, because of meningitis, any of these reasons. You could have movement disorders, which is vestibular. So you have to ask them what happens. Because for this, if you add Dexa or if you add mannitol thinking, oh, it's cerebral issue, then you're not going to be actually treating the cause. So your history becomes very important to differentiate. Cerebral metastasis more during the morning. Activity, movement more towards the vestibular. Okay. You have medications, as madam very rightly said, opioids. And opioids have different ways in which they produce nausea, vomiting. Chemotherapy agents, mucosal irritants, your NSAIDs. We've had patients who are on aspirin, ecosprin, but they're not taking their PPIs. They're not taking any omeprazole or pantoprazole or any of these, and they cause a lot of gastritis, a chronic irritability. Hyperacidity, gastroesophageal reflux disease. So history as to the timing of the pain. Does it wake them up? What happens when they eat? What are their food habits? All of these also go a long way. There are a lot of people who present to you, and I'm not talking about people who are really in the supportive care end towards advanced disease. I'm talking early times, where there are a lot of IT professionals, especially in our country, their timing of food is completely messed up. They don't sleep. If you are people who are actually working in another time zone, then they are awake during the night, sleeping during the day. All of these things are going to completely mess up the body routine. So if you don't go into what is their social, their the cultural, the education, or the occupational history, you may miss a lot of reasons why they have this nausea, vomiting. Mechanical, again, as in malignant bowel obstruction, please remember that the obstruction can either be within the lumen, in the wall of the intestine, or it can be serosal or peritoneal and omental. Any of these reasons can cause malignant bowel obstruction. In addition to that, you could have adhesions because they've had previous surgeries, or you could, nowadays, there is a lot of HIPEC and PIPAC going on where it's intraperitoneal chemotherapy is given. So one is pressurized and the other is hyperthermic. So when you have things like this, though they help the patients, there are complications that arise from this. Kindly take a history, kindly find out what is going on. Next is motility, could be because of opioid, ileus, and even medications such as Buscopan, Emiset. These are the medications such as Emiset are used for nausea, vomiting. But what happens is a chronic use of Emiset leads to constipation. Constipation will again cause nausea, vomiting. Ileus can be caused by electrolyte disturbances. Buscopan is used to decrease intestinal motility, especially where there is colicky pain, but that could inadvertently lead to motility issues and constipation. So do keep an eye out for these medications. As I told you, metabolic causes, microbes, so esophagitis, candidiasis, H. pylori. Please don't forget that any patient who comes to you with a life-limiting illness cannot be looked through the microscope of the life-limiting illness. He's any other human being who could face stress and issues with these infections that another ordinary population can also face. So kindly look at it. And the other thing is mentation, which is anxiety, as ma'am said. Also remember that a combination of medications can also have issues. Last but not the least, please do not forget the heart. Many times inferior wall MI are all as gastritis, as nausea, as vomiting. So please do not forget to look into cardiac issues. Okay. The other thing that we have found is that patients who have a lot, moderate to large pleural effusions, because of a deviation of the esophagus, because of the pressure on the esophagus, nausea is something that they do present with. So do keep an eye out for anybody who has lung metastasis, who's had mild pleural effusion in the past. Look and see if it has worsened. Medications, already madam has gone through it. These slides are yours. You can go through them. I just wanted to put a slide about the elderly. There are people who are in geriatric palliative care or oncology patients who are elderly patients. If you look at the last two, debility and unrelated, across the board, it is the same issues that they face. It's just that in cancer, you have additional issues. Cardiac, you have additional issues. In chronic obstructive pulmonary disease, you have different issues, and end-stage renal failure, you have different issues, and dementia, Parkinson's is one of the kind of dementias that you could be faced with. Supranuclear palsy, these are things that you could be faced with. So they would be receiving medications. They have a lot of secretions, especially dementia patients or cancer patients or even end-stage renal disease. Any of the medications that help decrease secretions are also going to thicken secretions. Thickened secretions are going to make them feel nauseated. Many people tend to cough, 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 and with the force of coughing, at the end of it, they do vomit. But that does, so the management of that vomiting is not to put something for nausea vomiting, but to try and manage the cough. So please, I cannot emphasize enough the importance of history. So non-pharmacological measures, I think Madam has already spoken about it, but I'll just put a few slides about olanzapine. As ma'am said, 10 mg is what is there. But in my clinical practice, I've never had to go beyond 2.5 and sometimes 5. I have very rarely used 10. And even with 5, they start to get quite sleepy. In the scale of antipsychotics, olanzapine is the one that causes the most amount of drowsiness. And so we should use it for our advantage. So use it mainly at night if you must. A higher dose at night, for example, 5 mg at night, it helps relieve the nausea. It also promotes sleep. So use it to your advantage. Use the side effects or the adverse effects to your advantage. And as ma'am said, olanzapine is a good medicine and a second-line medicine, mainly because though there are many receptors to nausea vomiting that we have discussed, olanzapine seems to block most of them. And hence you have the relief. Many times what it is that we think, I mean, everybody in India, across the board, if we ask anybody, what's your favorite antiemetic? Everybody says Emicet. Ondansetron, because it's at the end of your hand. You can get to it easily. And it does work. It doesn't mean that it doesn't work. But being palliative physicians, having gone through this, our thought of prescribing should be much more receptor-based rather than just a generic, common sense-based thing. So these are all the studies that are there in supporting olanzapine, especially chemotherapy-induced nausea, vomiting. In advanced disease, because as Sonal ma'am said, you have a lot of sublingual medications. They melt. So there are patients who can't swallow, who are not able, they're not awake. But sublingually, you can still use it, especially when you're at home. If you don't have access to IV medications before a nurse can be called, you know, in India, how difficult it is to get nurses to get home in time if there is prolonged vomiting, and always getting to hospital can prove to be a very, very difficult task. So use olanzapine to your benefit, okay? Now, stomas. Now, ma'am talked about malignant bowel obstruction. Many times in palliative medicine, especially if you have abdominal malignancies, this is the thing that we resort to. So you either have ileostomy, which is on your right-hand side top corner, or you have your colostomies, which could be ascending, transverse, descending, and sigmoid. It could be any of these. And this is something that we are used to. But these stomas also work only if there is a single obstruction, if you don't have peritoneal disease, if there are no adhesions. Because the minute you open, please remember, you're predisposing a cancer patient to further adhesions. And it becomes very important to explain to your patients and the relatives that just because we put a stoma now does not mean that there isn't going to be an obstruction somewhere else proximally another time. So every time a stoma cannot be put. So we hope and pray that that stoma that is there, that is going to functionally benefit the patient. So patient selection when you're doing a stoma becomes very important. If the thought is that this stoma is going to come in here and I'm not going to have any problem hereafter, they are actually going in through quite a distressing procedure with no benefit afterwards, because they are going to be emotionally and psychologically extremely distressed. Okay. Involving a psychologist if stoma is involved, it becomes very important, because the pros and cons, the difficulties post-stoma has to be told to them before they go through the stoma procedure. If you have somebody who has undergone a stoma procedure and they can talk to the new patient, then that is also very beneficial, because I can say I understand the issues, but I've never been through it. So it becomes very important to help get these kind of links going on. And then you have the PEG feeding. PEG can be used for feeding, percutaneous endoscopic gastrostomy. It can be either used as an input stoma or an output stoma. That is the venting gastrostomy, okay? So we are confident, we know about these things, but then what is the way forward? Now everyone's moving endoscopically. They're actually now talking about what I can do in minimally invasive. So there is something called as the G tube that is placed in the side of the neck. So it's a percutaneous, can you see? It's a transesophageal gastrostomy. And this is something that can be used. And in some patients who, let's say, have a cricoid issue, or they're not able to go through endoscopically because of a stricture that's proximal, as you can see in that picture, it is possible to do this procedure. So these are things that are out there in the world that people are trying. I'm not sure if everybody in India is doing it. There are certain select centers. If any of you are surgeons who are there today in the talk, and if you'd like to add light onto this, it's most welcome. If not, if you go back to your institutions, find out from your gastroenterology team, your medical gastro team, what is it that they're doing? There is also the option where we used to actually do a gastrojejunostomy surgically. Nowadays, there is the ultrasound, endoscopic ultrasound guided gastroenterostomy. So they are doing a similar procedure, which you can see is a stent that is placed between the stomach and the intestine, the small intestine, distal to the obstruction. Now, I had a patient recently, came in with a huge stomach. We drained about 6 liters of fluid from it. He hadn't presented to us for a long time and then suddenly came like this. And he had this procedure, and his distress was that he did not want a Ryle's tube, because the people in his village are going to look at him and ostracize him. So he said, even if I have to drink water and tender coconut the entire time, I have no problem, but you make sure that I do this. And he had a bit of peritoneal disease. He had minimal ascites. But against a high risk, the gastro team did go ahead and do this. And he lived for a month and a half, having liquid food, but walking around such that nobody else in the village knew that he actually has such a dangerous or such a bad complication to his cancer. He hadn't told anybody. And as you know, in India, in society, not divulging cancer can be a very, very socially ostracizing situation and open for comments and which are not very helpful. So this had proved to be a very good option for him. And he was out of the hospital in 24 hours. So his inpatient bill, everything was to a minimum. The other is pyloric stent insertions, which are done in malignant gastric bowel obstructions. Again, pros and cons of all of this, the tumor growing, these are all palliative interventions that can be done for patients who have refractory nausea, vomiting. And for patients, for example, who cannot eat, the acidity, the distress, the nausea, the constant brash that is there, they all get a little better with these procedures. It is the papers are here. Please do open it. It is easily accessible. Please read through them. I can't present everything here. So Madam had actually talked about cannabinoids, and our thought is this the way forward? So the Multinational Association for Supportive Care in Cancer actually had a consensus guidelines about cannabinoids in gastrointestinal system. So there are only two parts to these cannabinoids. It's all from hemp that we really need to know. It is the tetrahydrocannabinol, and you have your the CBD. Now, the ratio of these two is what helps, all right? So Mass actually found that there was insufficient evidence to recommend cannabinoids in management of chemotherapy-induced nausea, vomiting, advanced cancer, cancer-associated anorexia, cachexia, and taste disturbance. So there is no guideline here to say that this is going to work. But as you know, in India, CBD oil is very easily available. And a lot of people think for pain, for nausea, vomiting, for sleep, they want to take the CBD oil. We have a lot of medical reps who come to say we can actually help. But if we are going to use it, then we need to use some evidence-based practice. The reason is this. Now, ESMO, which is another giant in oncology, has actually tried to do this randomized study for refractory chemotherapy-induced nausea, vomiting. Now, the table in front, don't worry about it. It basically assessed the functional living index as well as the assessment of the quality of life in 8 dimensions. The dimensions are there. Now, what they found is that, yes, if compared to a placebo, the THC and CBD combination, they did show that there was a betterment in it, okay, compared to the assessment of the quality of life. The quality of life didn't show so much improvement, but this symptom seemed to actually functional living improved. But what happened was they found that the side effects, the adverse effects that was there with THC and CBD was much higher than a placebo. I hope you can see that. So they actually said that there is no great improvement over an antiemetic that we've already heard about in the previous lecture and what I showed in mine. There is an improvement of some functional living index, functional living, are able to do what they have to do, but the adverse effects were actually much higher, especially when you combine it with opioids, when you combine it with other drowsiness causing agents. So we have to be very careful. So like I said, herbal cannabis, which is cannabis sativa, has tetrahydrocannabinol, and it has cannabinol, also called as CBD. Now, as you can see, THC is the one that is psychoactive, and the physical effects of cannabis is actually seen through that, okay? And it's more pharmacologically active. CBD, on the other hand, has very little psychotropic effects. So it is a balance of these two that actually makes a difference. But there are commercially marketed cannabinoids that is available. The one thing that we also have to remember is that there is something called as cannabinoid hyperemesis syndrome, okay? So you could have people who are coming and you've taken a history, you've tried to find everything, and you're not actually able to come up with an answer as to why these people are like this. Please take a history. Today, CBD oil is actually available so freely, and people do not have an idea yet, because it is not evidence-based, how many drops are required. And hence it is all still trial and error. And if you are somebody who is not going to respond appropriately to a cannabinoid oil, or if you have a lot of polypharmacy, and if you're going to land up with interactions, this is something that you should keep in mind. There will be a history of regular cannabis use. They have cyclical nausea, vomiting, and the minute you stop the cannabis, it gets better. They have abdominal pain, and there is a lot of irritability as well. So just keep your mind open that there is something like this, so that if you do have refractory nausea, vomiting, it could very well be they're using some things that they have not told you. The other thing in India is also Ayurvedic treatment, homeopathic treatment. Now, none of us know what is in the Ayurvedic powders that they give. Many times there are steroids in it and heavy metals in it. So those are stories and histories that it becomes very important for us to take. And also in the Indian population, compliance to medication is not the best. In addition to that, if you tell them, for example, any of your antiemetics have to be taken 30 minutes before you eat. If they pop an Emiset and they eat immediately and they are going to feel nauseated and vomit, then it is not that Emiset didn't work. It becomes very important that we find out how they took their tablets. Many times we say give olanzapine sublingually, but they would have swallowed it. And when you have nausea, vomiting, if you're going to give medications that you have to swallow, you're probably not going to have the best effect as you would if you had it sublingually. As of now, Perinom is not available sublingually, but even ondansetron, which is Emiset, is available sublingually. So kindly look into how many times they're taking. Are they taking the medicine as you have prescribed them to take it? And what is the route of administration that they are giving? So the take-home points from my end is always take a very detailed history. Like Madam had said, every time there was a new symptom, and you have to handle it like that. Kindly do a very, very detailed examination of a patient, however busy you may be. Look into the mouth, please. Look at the nails. Look into their abdomen. Examine it. Understand what it is to have a malignant bowel obstruction. What is gastric outlet obstruction? How do small bowel obstructions present? How do large bowel obstructions present? You will have to have an idea of these if you have to handle it successfully. And always do it in an interdisciplinary approach. Get your teammates, they are your best friends. Ask your gastro for an opinion if you don't know what's going on. And get your medical people to actually have a look and see, examine your electrolytes, make sure that you've not missed anything. And once the patient is bedbound, please remember that the amount, if you're giving a Ryle's feed, make sure that they are feeding in the right position, in semi-Fowler's position. Many times they're fed sleeping, or the minute they are fed, they're made to lie down. Now your nasogastric tube is in your gastroesophageal sphincter, so it's not going to close completely. Keeping them fed in that position, keeping them continued in that position for at least half an hour to 45 minutes is what is going to help move things forward. Whatever happens, even if they're bedbound, they should have passive and active exercises as far as they are possible, because that is going to help in gastric motility. Get them to ambulate to a chair. It is possible, at least to sit up in bed. Any movement is good for intestinal motility. Please ensure that it is done. And education of the family members is very important. Writing a prescription and giving it to them without actually explaining it in detail to them. And most important of all, in the Indian setting, Tell it to the person who is caring for the patient. Many times a relative brings the patient who is not the person who stays with the patient. And by the time they go and transfer the information you have given, it's like Chinese whisper. It's something completely different to what you said. So kindly find out who the primary caregiver is, and education should be to that person. Always consider non-pharmacological measures. Your ginger, lemon, a few mint leaves, or in India, tulsi leaves, held in a thin muslin cloth and inhaled make big differences in a person where smell is concerned. Our food is very spicy. Kindly, if they're nauseated and vomiting, ask them to cut down the spice, cut down on the chili. If they have to use the chili, ask them to take out the string in the middle with the seeds and use only the skin. It gives the heat without, it gives the taste without the heat. Pepper pods can actually be used instead of pepper powder. Even if you use the badige mentionkai, the red chilies, please take out the seeds and use the skin. You get the taste, you don't get the heat. So these are all little things that the relatives would be looking for, patient is looking for, rather than say, just have a bland diet. After some time, that in itself gets very nauseating. Okay, and keep in mind that if they are taking antiemetics, find out how many times. Always use the Bristol stool scale to actually monitor your constipation, because sometimes not sometimes in India, the thought of constipation is that if I have not gone for 2 days, only then I'm constipated. But that's not true. Constipation could be if I have had incomplete evacuation, I'm sitting longer than I need to sit, I'm straining, it is incomplete evacuation, I have a bloating in my tummy after eating, I can only eat a small amount. Any of that can also indicate constipation. So please look at your Bristol stool scale, get the history of your constipation, nausea, vomiting, what is their lifestyle like. It will be amazing to find that how little sometimes need to be changed in order to have a relief from nausea, vomiting, which is not organic in nature. Reassess. Now, the cause of nausea, vomiting that they come to you on the 5th of April does not have to be the cause of nausea, vomiting on the 10th of April, because the causes, as I told you, are so many. So don't go back to what your previous diagnosis was and say, this is it. Re-evaluate, retake a history, redo the examination, rethink what your differential is, because every single time it could be a different cause for nausea, vomiting. Have an open discussion with the family, and the most important thing, kindly document everything that you have spoken and told them. In the rise of medical legal cases, please watch out for yourselves that everything that is possible has been spoken to the family. So kindly make sure that you document. So me and my stomach, thank you for listening.
Thank you so much, Amelia. I hope that doesn't mean that you're so hungry because you're staying back in the hospital for so long.
No.
Conveying to all of us that my stomach is a little hungry now. Thank you so much. And thank you so much for the practical points that you have been telling, especially the history taking and the non-pharmacological ways by which we can manage many of these things, which are often overlooked. We try to jump into the medication as soon as we take the history, right? We want to fix it then and there, and then we forget to talk to them about all of them here in southern part of India. They'll be on kani, which is the rice ritual, and nothing else for days and weeks, and that's not something people want to have while they have nausea, vomiting. Thank you so much, participants. If you have any questions, please type it in the chat or unmute yourself and ask. Or if you have anything to share from your own practice, which was not discussed in the session, please share in the chat or unmute yourself. And thank you so much for that update on cannabis, because as you said, so many people are behind using cannabis for many purposes, and then we don't have evidence and we don't know how to use it, whether it has how much to be given, how impactful it is going to be. What is it that we are going to face in terms of interactions and stuff. So yeah, thank you so much for that. We will wait for questions, and meanwhile, shall we go on to the case presentation so that we are not can save a little bit of time over there. Shun is also on duty, so but she's there in the session. with her presentation. Over to you, Dr. Shun.
Hello.
Yes, yes, we can hear you.
Good evening. I am Dr. Sean from Myanmar, and today I would like to present next 32 years old male with the diagnosis of recurrent carcinoma anus with peritoneal metastasis, intra-abdominal nodal metastasis with the problem of malignant bowel obstruction. So the presenting complaints are pain in abdominal region for 3 days, vomiting off and on for 3 days, abdominal distension for 1 week, constipation for more than 2 weeks, and severe pain in perianal region for 1 month. Next slide, please. So regarding history of illness, he has been diagnosed as the carcinoma anus, adenocarcinoma, since 2021. At that time, he had undergone operation, APR, and colostomy, and then he did not receive any further treatment, and he lost his regular follow-up. In October 2022, tumor recurrence occurred, and his CT abdomen results show tumor recurrence with invasion to the prostate, and together with pelvic lymph node and inguinal lymph node. So he was given 8 cycles of chemotherapy with a 4-FOX regime and pelvic radiotherapy 25 fractions. Despite those treatments, his disease became progressive, and the recurrent anal mass extended to the perianal skin as the perianal abscess. Next slide, please. In April 2023, he presented with pain in perianal region, pain in abdomen, abdominal distension, vomiting, and constipation. Regarding the constipation, at first it was just partial, but later it became absolute and without causing any flatus from colostomy. Next slide, please. And as a result, his abdomen became distended gradually. His abdominal pain was, he also had an abdominal pain which was colicky in nature and rated by death. It also was associated with vomiting, and he vomits the bile-stain vomiting like the fecal smell, and it's more pronounced especially after eating something. He also have the perianal pain, and it's very severe, more severe than the abdominal pain. And previously, he had taken the transdermal fentanyl 25 microgram per hour, but at that time, perianal pain was no longer be able to control. It was very severe, rated 9/10. It was dull aching, and so because of pain, he could not sit well, walk well, and there was also sleep disturbance. He also had appetite loss and severe weight loss. On examination, the patient looked a headache and dehydrated. He was mild pallor, but no jaundice. Temperature was normal, and he looked slightly dyspneic. And vital sign was stable, but there was mild tachycardia. His abdomen was distended but soft, and bowel sound was slightly increased. And colostomy is not well functioning. And there was also ulcerated wound in the perianal region with a pus discharge, which was about 2 to 3 centimeter, ugly, irregular shape with raised margin. He also had a bilateral inguinal lymph node, and his urine output was normal. Next slide, please. On CECD abdomen and pelvis, there was large solid cystic presacral mass with local invasion and perineal invasion, likely tumor recurrence, and casing prostate and invading bladder. Related peritumoral abscess formations noted in the left pelvic floor and left gluteal region, and large bilateral inguinal nodes up to 2.9 centimeter, likely metastatic nodes, peritoneal metastasis, anterior abdominal wall metastasis, mild and moderate left hydronephrosis, and small ascites was seen. Next slide, please. On plain X-ray abdomen, there are multiple dilated abdominal bowel loops with multiple L fluid level. And his hemoglobin level is 9.4, WBC is 13.5, platelet is 431, and albumin is slightly reduced 2.94. And there is also electrolyte imbalance, sodium 129, potassium 2.8, and others are normal. There was pus discharge from perianal abscess, and culture and sensitivity results show the growth of E. coli. Next slide, please. So we kept him nothing by mouth and rhino draining for decompression and in order to rest the bowel. At the same time, we gave IV fluid and electrolyte replacement according to his output, and we provided pharmacological management of the malignant bowel obstruction. At the same time, we corrected the reversible problem of the patient, like the anemia, and like that we correct the electrolyte imbalance. In this patient, nutritional management is so important, and so we give not only the IV electrolyte replacement, we set up a central venous line, and we gave the TPN and other nutritional management. And at the same time, we do the other symptom control measures and care, like the pain control, like wound care, oral care, bladder and colostomy and tube care. Next slide, please. So these are the medications that we give to the patient. IV dexamethasone 8 mg BD, IV pantoprazole 20 mg 12 hourly, IV trodelvin 8 hourly, and IV antibiotics were given according to the CNS results, and IV infusion fentanyl 50 microgram per hour, and it was titrated according to his pain. And at that time, we stopped all the oral medication to rest the bowel. Next slide, please. So in his management, we use the multidisciplinary team approach. We consulted with his attending surgeon and medical oncologist, radiation oncologist, GI and other specialists, and also his the primary doctor nurses. And we also discussed about the patient condition with the patient, as well as with the families and caregiver. We explain the available treatment option, which are the risks and which are the benefit for the patient. And we also educated his family how to support the patient. We also assess the patient goals for treatment and to guide choice of intervention. Next slide, please. So at that time, due to the poor performance status and the patient were very hectic and debilitated, palliative chemotherapy was unfavorable. Any surgical intervention or palliative radiotherapy was also technically not feasible for him. So we have only the conservative and pharmacological supportive management for that patient. Next slide, please. After 2 weeks of hospitalization with this conservative management, his symptom became reduced and patient performance improved. His pain became stable with a transdermal fentanyl 900 microgram per hour. So we introduced the oral intake gradually, starting from the liquid sip. But unfortunately, patient could not tolerate the oral intake at all. And after 1 week of starting the oral intake, his symptom became worse again. His brain drainage output was increased again. It was about 250 cc per day with a bile and fluid with a fecal-like smell. And at that time, bowel output was totally absent and bowel sound was sluggish. So the patient was kept nothing by mouth again. And in addition to the pre-given medication, we started to give IV glycopyrrolate 8 hourly and subcu ultraliotide 100 microgram 8 hourly. At that time, patient also get the insomnia, so we gave sublingual ebrasolens 0.5 milligram HS. Next slide, please. In fourth week of hospitalization, the patient's symptom became reduced again. But his progression was not satisfactory, and there is only slow progression. His symptoms did not relieve completely. Once we tried to lower the medication dosage, the symptom become worse again. Once we try to introduce the oral intake, they become worse again. So as a result, the patient has to stay with the IV medications, parenteral nutrition, and esophageal drainage tube. And now he has very little output from the colostomy, no bowel output, and trying to drainage is the only way of output, and it passing about 100 to 100 cc per day. And on other side, his anxiety increased again, maybe due to the fat spacing or maybe due to the progressive disease condition like the peritoneal metastasis. His abdominal distension and pain became pronounced again. So fluid intake had to be reduced for him, and other palliative measures like the aspiration of ascites have to be done at that time. Next slide, please. So as the disease progressed and the patient had the psychological impacts, he felt disappointed and he felt tired to stay with the Jew. He hated himself as he was unable to eat or drink, and he said it was disgusting to pass fecal-like output through his nasogastric tube. On the other hand, he was afraid of arthritis symptoms like the pain, abdominal distension, vomiting, and these symptoms appear after eating. So on one hand he want to eat, but on the other side he was afraid of pain, so he had the fears of eating. So he thought that it looked like a punishment for him, and he was reluctant to meet his friend, and he became socially isolated. And regarding his family, he's the youngest son. He lived with his parents. His family came from the moderate socioeconomic level, so they all take great care of him, and they all give their best support to him. At that time, the moral support, and not only the physical support, the moral support from the family is very important. So we educate his family and his caregiver how to support the patient. Next slide, please. In this case, the main concerns are quality of life for him and his concern, and about his gastric tube, and his desire to his concern about the limitation of oral intake and his desire to eat orally. And another concern was his emotional and spiritual issues. Next slide, please. So to be summarized, 32 years old male with recurrent carcinoma anus with an extensive local invasion and a lot of the peritoneal intra-abdominal metastasis, and with a problem of recurrent malignant bowel obstruction. Next slide, please. So these are the discussion points. In this case, how to improve the patient's quality of life. Should we remove the nasogastric tube? Should we allow the oral intake? Should we follow his desire? It can be dangerous for him. And then how to help him to accept this condition, how to help him to cope with this condition, how to help him to relieve his emotional and spiritual concern, and what would be the post-hospital care planning for him. So thank you for attention.
Thank you so much, Dr. Shun. I would like to see some charts regarding your opinions from the participants. I'm sure most of you might be seeing or facing these kind of situations in your practice. I mean, I know that it is a very challenging situation given the multiple episodes of obstruction, and above all, fecal matter vomiting is something people, I mean, as healthcare providers, we also find it very, very difficult, and it brings in a lot of concerns from the patients. While we are waiting for the chat, I hope you will be sharing some of your experiences, other participants. I would like to ask Dr. Amelia also. I understand there are a multitude of problems for this patient, starting from the feeding and the pain and the symptoms and spiritual issues above all.
So thank you for the presentation, Dr. Shun. I get it that it is one moment it is very distressing to see somebody. At the next moment, it's frustrating that with all the medications we're not going to help. And also, I think it affects us very deeply. Regarding your first question, how to improve the patient's quality of life, I think you should give yourself a pat on the back, because you have improved his quality of life. Because if you had not done all that you did, whatever he has continued to survive for the periods between his obstructions, he would not have had it. Okay. Now, I understand that the expectation is very high. The expectation we put on ourselves also is very high, that we hope that we can sort everything out. And the expectation the patient has also is that I'm in a hospital, everything should turn okay. So I think the constant talking and with the family members and the patient is important. And I don't think we could have done anything differently. You've used all the medications that could possibly be used in malignant bowel obstruction. With regards to removing the NG tube, I have had quite a few patients who have gastric outlet obstruction. And there is, or in small bowel obstruction, there is some amount of fecal matter that comes out. It's a handful I have seen where it's just frank feces that comes out. But if you put a bigger size NG tube and you leave it out for dependent drainage, one advantage is it all comes into the bag. It is when it has to come out through the mouth that it becomes very psychologically, emotionally, socially, extremely distressing. Okay. The difficulty is if the fecal matter is thick, your RT tube gets blocked. So you might need to aspirate it every 4th hourly if you're getting fecal matter. But otherwise, asking them to drink something like a little bit of Sprite or just clear water does tend to open up the pores in the Ryle's tube. And ineffectively, you are actually telling them that they can take orally. But everything's got to be double strained, you know. But it is possible. So I've had patients who have taken about 500. In fact, right now I have a patient who's taking about 500 ml per day. Her Ryle's tube output is about 700 ml to 800 ml. But she's taken the 500. That 500 probably 450 ml has come outside in addition to the gastric juices. But that's okay. She's actually taken the thought that I have taken orally. She was able to take some coffee, which is in your South India, without coffee, life is like, you know, I've not had coffee, even if it's just a few sips. So that way, if you're thinking of quality of life, and you did say that he was extremely distressed that he could not take things orally, sometimes this comfort feeding helps. So this is what is called as comfort feeding. So that's something you can do. So that's your third question. Otherwise, I think you've handled everything. It's not possible for us to sort out all the problems. It's not possible. And it's every patient's personal journey. And many times you will have to sit and listen and feel helpless sometimes that you can't do anything about what they're saying. But listening in itself, you have improved his quality because somebody's there to listen. At home, most of the times in our Indian population, they say, you know, because they don't know how to handle the question, it's like, be quiet. Why are you talking like that? Nothing like that is going to happen. It's all going to get better. You know, there is this sugar coating of everything. And that in a way disappoints people because they think, okay, it's going to get better. But in a while, nothing has got better. Things are worse. So that is something that, you know, you can look into. Opioid-induced nausea vomiting is something that you could look into, especially if you're into high doses of fentanyl and things like that. So that's something to keep at the back of your mind. And anxiety in itself will cause him a lot of nausea. So giving him alprazolam, I find, doesn't work as much, especially when there is death anxiety. I hope you all know what death anxiety is. When there's death anxiety, alprazolam does not work. You need something far stronger. So you can put this one, lorazepam sublingual. That helps. So that is something you could try. Alprazolam is too mild for them. We've had to sometimes give as high as 1 mg to 2 mg of lorazepam sublingually. It does make them sleep. And in patients where there is such a lot of emotional, spiritual, physical distress, if his condition was too actively declining and all symptoms are refractory to any kind of change that you're trying to make, then palliative sedation is something that you all can think about. Hospital care planning, post-hospital care, I think education is the most important thing. And that too of the person who is going to stay by his side all the time. If you're going to have a nurse or a caregiver, then they have to be educated. Otherwise, they will run away, especially if there's fecal output coming out, because it's not a nice feeling, you know, to have to clean that. And the smell is always something that distresses. So if instead of using aromatics, perfumic sprays, charcoal is a very good thing to use. Okay, you can get activated charcoal, or if you're in a possession of bark or wood anywhere, you can burn it, you make fresh charcoal, and you put it in the room, it absorbs malodor really well. That's why in colostomy bags, some of them have charcoal in it so that the smell is not there. So those are little things that you can do. Use natural products like lime and things like that rather than chemical perfumes. It mixes together and gives a very disgusting smell. So you could try that.
It's very helpful. Thank you.
Thank you, Amelia. Just as you said, I think Dr. Shun has done almost everything possible that we all have done. So, and I'm glad that you could get into the bottom of all these problems. Unless you have had a good conversation, you wouldn't be telling us that this is what he thinks about the fecal matter vomiters. Is it being a punishment, or I don't want to go out? Unless you go deeper in terms of conversation, you won't get these details. You would have stuck with the physical symptoms only. So I'm glad that you got those many details. So that listening itself would have been a lot of, it's like a therapeutic way for him, because someone is there, especially you being an oncologist, going into the deeper levels, they feel much comfort because the treating doctor itself is hearing than someone else from the team. So that's very appreciable from that's something I wanted to share. I'm not sure the role of olanzapine and other drugs because all of those things you have tried here, and I totally agree upon the comfort feeding that gives a lot of satisfaction for the patient. Like we had patients like they wanted to taste biryani, so a spoon of biryani, just chew, and sometimes they spit it out, or sometimes they chew and eat, and they know that the bowel is going to, as you mentioned, they know that it is going to have pain is going to come, or the distension and discomfort is going to come. Then they try to drain it out whenever they. But the patient was so satisfied that okay, I could taste the biryani. That's all, and the family members also was relieved because this patient tasted it, or otherwise it's just us eating and sitting around him. So those are things that we also do. So there is nothing more to add from my side. And thank you so much for bringing in that. I mean, you have gone into the details, so it was very clear for us what all has been done and what the patient has gone through. Thank you so much, Dr. Shun. Surprisingly, there was not much questions from the participants. Otherwise, there are a lot of questions. But everyone has appreciated today's session, and everyone has given a lot of compliments in terms of information, a lot of information from today's session. Thank you so much. We overshot by 3 minutes. I'm so sorry for that. Thank you so much, all the participants, for being with us. Thank you, Dr. Amelia. And thank you, Dr. Shon, for.
Thank you, Shri, for calling us. Bye. Take care.